At IAS 2023, we start by honoring the traditional custodians of the land and pay respect to their elders, past, present, and emerging. We will hear from Dr. Bill Kapogiannis, who's going to talk about NIH's Office of AIDS research priorities and how the research presented here at the conference can support those priorities. Please enjoy the video.
Hi, I'm Katie Laube with the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health, and I'm here with HIV.gov at day 3 of IAS 2023. I'm so happy to be joined by my colleague, Dr. Bill Kapogiannis, NIH's Acting Director of the Office of AIDS Research. Bill, thanks for joining me here.
Thank you for having me, Katie.
Of course. So it's already been a very exciting week. We've heard updates on a spectrum of HIV science. What has caught your eye so far this week?
I think the really impressive data is the Reprieve study and what it means. I mean, it really is a game changer for clinical guidelines and affecting particularly the populations of people with HIV. And traditionally not a population that would typically get treated, and so low to moderate risk of developing cardiovascular events. And so here is a study that really demonstrated a very significant, almost 35% decrease in major adverse cardiovascular events, which include stroke and myocardial infarction. So really a game changer again for guidelines to really improve outcomes in this population.
Yeah, it is quite a moment to be sitting here sort of on the precipice of a potential change to the standard of care, depending on how guidelines committees review it. And so you joined the Office of AIDS Research, or OAR, in the last year and have been busy with a number of things, but among them are OAR's signature programs. Could you tell us what those are and if there's been any research at this conference that illustrates why those are important?
I think there are a number of programs that are probably relevant. We have 4 signature programs. I think of those, the ones I'll highlight are just mentioning Reprieve and the HIV and Aging signature program, as well as the HIV and Women's, because of course the Reprieve results are relevant to women as well, and so they're really important and really to fill gaps in understanding differences, for example, for women, and what the physiology is like when we're trying to apply the results of Reprieve and how to use that effectively to prevent events in that subpopulation. And so those 2 programs. The third one I would mention is the data science initiative, and I think that really there's been some interesting results that really were provocative for me, and kind of helping me think about where does the field go. And one of them was the early talk today on by Jean-Michel Molina on the STI prevention and using doxypep. Mm-hmm. And so one of the take-home messages of the caveats on how to use that effectively when you're, as a clinician, thinking about rolling this out to the population, are you going to be able to? One of the recommendations was, 7 days before, it would be helpful to have a negative STI result before you start somebody. And so, mm-hmm. How do you implement that practically? You really need diagnostics to be sort of at the cutting edge and develop technologies that you can have at the point of care and at home, maybe ideally, so that people can use them. And so that's one aspect. And the other is a talk that I just attended on earlier today, the topic of Levi syndrome, or the long-acting early viral inhibition phenomenon that seems to have occurred in using the cabotegravir injectable for prevention, and having that potentially the ramifications of having acute infection or seroconversion while you're on an agent, and the broad scale up of implementing this, and how could in an implementation in countries that will be using this, for example, how are they going to be able to detect new infections that are occurring if they're on these long-acting agents? So technologies really need to get better at being able to help identify those.
Yeah.
So that's what I would say, those two pieces.
Yeah, no, it's exciting and important topics that are coming up. And just for those that don't hear about Levi syndrome very often, maybe we could just elaborate for them. So this is the issue where if you're taking long-acting cabotegravir, you're not going to be having a positive HIV test even when you may have recently acquired HIV?
Correct. So what happens is, the long-acting early viral inhibition that it stands for is that basically, you're on this medicine and you're not, kind of coming on and coming off of it. You have a steady high level of it, and the virus kind of gets suppressed so that it's at a point where it's not getting your immune system to recognize that it's there and form that initial immune response, which is critical to our diagnostic tests. And so that's where it starts to come in. And then you need to be able to find a way to detect that when it's very low level.
Yeah, great. And so again, reflecting on the research that we've heard about thus far, that we still have a day left, what are the implications from your point of view for NIH's HIV research priorities and for the HIV service community? So sort of both ends of the spectrum.
So I think, great question, Katie. I think that on the research priority side, we've heard some really fascinating talks, particularly around the vaccine and immunology arena, and trying to really think strategically about how we move that forward. And I'm alluding to, in this case, the broadly neutralizing antibody talks that we had, and how to really take those to the next stage. And so I think we have to think strategically about how we support research that really helps bring the BNAB's agenda forward, and particularly as I'm thinking about being a pediatrician and child health before at NICHD, eliminating perinatal maternal or mother-to-child transmission, to be able to use this technology, to this medical innovation. And so I think that's on the science side. On the service side, sort of kind of looping in back to the REPRIEVE results a little bit, is sort of the priority that we have at OAR on cross-cutting issues and trying to advance those. And what comes into play there are the multimorbidities that are experienced by people who are aging with HIV, and then being able to loop in on the implementation science, kind of that service to science. I should reverse that, the
Science to service,
science to service gap, how to close that science to service gap, and working with the agencies across that I've been trying to start doing to coordinate our efforts so that we can best understand how we do what we do best, which is the research side and the implementation science that includes, but then be able to hand off and say, this is now where you guys in the services take it and run, and how we coordinate all of those activities.
Yeah, well, a lot of progress made, but it sounds like a whole lot of work left to be done.
Very much could not have said it better myself.
Well, thank you so much for joining us here, Bill. It was such a pleasure to talk to you and hear your point of view.
It was delightful. Thank you.
Yes, thanks. And thank you all for joining. Please stay tuned to HIV.gov for the rest of the conference. I'm Katie Laube. Thank you for watching.